All righty. We'll see how we do today. Those of you who have been to the meeting before know that this is kind of a freewheeling discussion. It's interesting, as I put it together over the years, a lot of the questions of the cases remain the same, but the answers are different. They really have changed. So that's kind of fun. So on our panel today, starting at the far end, is Dr. Lennox, who everybody knows from earlier. Then we have Dr. Gephardt, and Dr. Tiffany Walker is there. She'll be talking to us later about long COVID. Carlos Del Rio, a lot of you know, who's now the interim dean at Emory and having a great time. Wonderful time being a super administrator. We have Meredith Clement, who's here from LSU and Nolans. Got to say that right? Yeah, you're right. And Dr. Iran. So here we go. And Dr. Gephardt, did I mention you? Yes, I think I did. Okay, here we go. So all these folks, I've been a consultant for 2 companies you probably never have heard of. So there we are. And we're going to talk about antiretroviral therapy and weight gain and pregnancy and abacavir and STI treatment strategies. We'll hear an awful lot about later. And then strategies for those who have Mpox or COVID. So standard question, a 48-year-old guy, just recently diagnosed, viral loads 280,000, CD4 count 65. Labs are normal, genotype is wild type. Of course, you may not know that up front, but for the purposes of this discussion, you know that. Negative medical history, normal renal function. So in this setting, I'll let you look this over. We've got a lot of concepts here. We'll open up the clock and play a little music that might be different than before, or maybe the same. We'll see. And go ahead and vote.
Music has improved.
It's improved. I can't hear it though. In the Heights? I think so, yeah. Here we go. All right, so the one we use the most, it seems, is this fixed dose combination with bictegravir. Some folks went right to dolutegravir 3TC, some direct to inject without the lead-in, but let's give them the benefit of the doubt and say there's a lead-in. Some folks still going with abacavir, and let's hear from the panel. Dr. Del Rio. What does the dean's office vote?
I agree with the audience. I think that a single pill combination with an integrase inhibitor like bictegravir plus TAF-FTC, it's a wonderful initial choice, and I think it's probably the preferred choice. I think if you had, you can go the same way with dolutegravir, but if you're adding, the single dose comes with abacavir, right? So you need to know the HLA status on that individual. So if you're going to do dolutegravir with TAF-FTC or something like that, then you're talking about 2 pills. And if you were globally, that would be the first option because that comes as a single pill, but not in our country. So I think you're back to, simplicity is king. And I think as we have learned over and over, simplify your regimen and your adherence will go up, and your people will take their drugs. So I think the bictegravir option is the best option at this point in time.
Okay, good. Anybody want to support some of the other options here for equity and inclusion?
Well, I think that there isn't resistance in this particular setting. So dolutegravir 3TC would be reasonable, but the guidelines, both IAS-USA and the DHHS, but especially IAS-USA have concerns about low CD4, not because it won't work, but because there's very limited data in that setting. But I think that it's not an unreasonable choice.
That means it's reasonable.
Right, means it's a reasonable choice. I think it's a reasonable choice. Thank you.
See, the problem with words is that they have meaning. That's a big deal.
Sure. And to me, not unreasonable is not the same as reasonable. That's just me.
Okay. Well, that's reasonable. I think. Okay, Meredith, do you have a thought other than what we've heard?
I agree. I mean, I think dolutegravir is a second generation, and INSTI is also reasonable choice. And for some patients, because of insurance reasons, we have had to do either TAF FTC or TDF FTC with dolutegravir. But again, for the reasons Dr. Del Rio mentioned, with 2 tablets versus 1, I think is not as desirable.
Yeah.
But I would feel just as comfortable, from the standpoint of having a second generation INSTI on board.
So if we pull back to the 50,000-foot view, we've got remarkable choices, right? I mean, most any one of these, there's some recent data at the CROI on dolutegravir, darunavir that worked, and the real say, well, why wouldn't it? Well, remember back when raltegravir was released, raltegravir darunavir boosted did not work that well for reasons I still can't quite understand, except perhaps it was just not enough oomph from the raltegravir. But with the data at the CROI showed that darunavir boosted with dolutegravir was a reasonable option as well.
Yeah, the one thing I would add, they're all reasonable choices you mentioned, but using ritonavir boosting, using cobistatin boosting, I mean, because of the drug-drug interactions, we try to avoid those regimens.
Yeah. So that becomes unreasonable.
Yeah, exactly.
I see. Okay. And we mentioned the guidelines. So now we're going to go back to the future, and if we're going to go forward to the future, like in Back to the Future Part 3 or 4 or 2. We're going to go 3 years from now, and this is going to riff off of Dr. Iran's. So that, just to remind you who the case is here, it's on the right. And then here are some choices that are a little different, including islatravir doravirine that you heard about, and islatravir lenacapavir, and broadly neutralizing antibodies. It's amazing how the choices mirror pretty well what Dr. Iran suggested. I don't know how that happened. And then implantable, we didn't talk about that much, but could you get an implant that might be good for 6 months or a year, assuming the toxicity isn't there? Wouldn't that be cool? You just put it in and forget about it until 6 months later. All right, go ahead and vote. We were talking about Hamilton last night, and there are some people who haven't seen it yet. Okay, and we will go to Dr. Walker for just general principles because of Hamilton. What do you think of this, just having heard about all this? She's internal medicine trained, but has done a lot of work in ID, was an EIS officer. So what do you think as you look at these choices?
Yeah, I mean, again, I think there are a lot of good options that can be chosen. I think trying to target medications that really speak to the patient in terms of retention, being able to maintain a regimen, choosing a regimen that would be something that works with their quality of life, I think would be most important.
Yeah. Dr. Gepfert, thoughts on just assuming they all worked and there was no
I think
reasonable difference in toxicity?
Dr. Walker gave the answer.
Yeah.
I mean, it's personalized again, right? It depends on the person you have in front of you and what his preference for that. I will say that in our clinic, a lot of people are really wanting the injections now.
Yeah. I would say the injectables, and I would love the idea of the BNABs Q6 months. My only thing that I would say in any of those is we're going to have to reinvent how we do our clinics, right? We're going to have to reinvent how we deliver care. And right now we're having patients that we say, well, we need to see you every 6 months, and some maybe even every year because they're doing great. We mail their meds, they're doing fine, we don't see them, and now we're going to have to say, well, now we need to see you every 8 weeks, or now we need to see you, and that changes the whole situation.
Right. And then cost, we didn't talk about that, but broadly neutralizing antibodies are likely to be pricey. We look at the cost of ibalizumab, which when you need it, but it's about $120K a year. So, Meredith, what do you think?
Yeah, I was going to agree with Dr. Del Rio about I think the implementation hurdles are substantial, but like Dr. Scott and I were actually just talking about during Dr. Iran's talk is that I think we as providers underestimate the toll, the burden that daily pills take on our patients. It's just a constant reminder that you're living with HIV and the stigma that surrounds it.
Sure.
And I just think it's going to really remarkably improve quality of life when we can get to every 6 months. For
Mike, I think
Dr.
for-
Linux, yes.
Along those lines, I'm a big fan of the implantable,
Yeah.
because we've seen how successful it is, for prophylaxis against pregnancy, if you want to put it in medical terms.
Is that pre-pregnancy prophylaxis? Is that what you're saying?
Correct. So, maybe it's lenacapavir because the dosage delivery will be lower on average than the oral. And if not, I think an implantable dual therapy could be a game changer for a significant proportion of our patients.
I got to say, as I wrote the question, I was saying, wouldn't it be cool if we could just have somebody come by once every 12 months? It'd be a small procedure, but probably no worse than the draining of MRSA furuncle that we do in clinic all the time, right? How many have done that? Just a few? Wow, we did it all the time. Okay, but it wouldn't be that big a deal. So let's, for the interest of time, see what we do. So this is our post-exposure answer here, and okay, a lot of people just stay the course. Change wouldn't be prudent, but I love the people who picked answer 13%. That's me.
There's an elephant in the room that things may go generic.
Yeah.
And then this question of what you prefer is now.
Right. If we had a virtual hybrid meeting, I would repeat the question for the people at home, but there's nobody at home. So, so the question is, what about generics? We might as well pause on that. Do you guys have a feeling about? We have some generics now.
I mean, our hand may be played by the insurance providers.
Right.
They may tell us what to do.
I mean, when you think that for TDL, PEPFAR pays less than $1 a day,
Yeah.
then you can get, I mean, we can get the price of therapy in this country down to less than $1 a day. I think that's going to be the option, right? I mean, clearly we pay too much for our drugs in this country, and that is the major limitation, and that, I think, limits the options that you cannot do personalized medicine when you have cost really being the driver.
No, that's a good point.
The one thing that's interfered with some prescribing of generics is that if there's more than one tablet, then there's copay issues, and patients will complain about that. So we got some equilibrium to do here before we get to this. So a common question in practice: should I simplify an initial regimen? It's basically the same guy who showed up, but he got started on dolutegravir TAF FTC by the 1% of you who voted for that. But he's doing well. He's a happy guy. And his viral load suppressed, and his CD4 count has had a raging uptick. And now your question is, do you want to change the regimen or change it to dolutegravir 3TC to simplify it? And that becomes a single tablet regimen. Start an injectable with every 8 weeks, and or some other kind of choice. Go ahead and vote. This is in honor of all the people that vote for cabotegravir. So those people who have seen Hamilton know this song, and those who don't. So let's see what we got here. So a lot of George Herbert Walker Bush folks, not gonna debt. Change wouldn't be prudent, but let's turn to our panel. Dr. Iran.
Yeah, so I think all of us as providers what we should be doing is getting people on a therapy that's the simplest, safest therapy that fits into their life.
Mm-hmm.
And we need to ask them, right? Maybe I don't want an IM injectable every 2 months in my backside. I don't, but they may, and for all the reasons that Sandy and Meredith were talking about. And if there isn't a more successful study than the Gemini study, which was switching from 3 drugs to dolutegravir 3TC. I mean, there was one failure over like 3 years in that switch. So I mean, you may be comfortable, and the patient may be more comfortable being on 3 drugs, but I think we need to ask people what they want. So the ultimate, what happens may be what most people pick, but I think we just have to make sure that we talk to people and let them know that they have options, and then help them make a decision. It's not an emergency, so that's good. So anyway.
All right, so let me ask a real-world question from one of our audience members to me by text 3 days ago. And the story is the patient had been on a, let's say, BIC TAF FTC, but the renal function is going a little bit south and wanted to know about switching to dolutegravir 3TC. However, way back when, there was an M184V, and what about the use of dolutegravir in a fully suppressed patient for the last 4 years, going to dolutegravir 3TC with a hint of a M184V in the past?
I mean, I worry less about the M184V. I worry more about asking whether this patient has history of hepatitis B.
Okay, so assume hepatitis B is negative, and
I would be fine with that.
yeah, so I think it's kind of in a gray zone. There's clearly, you don't want to start with this drug, that regimen, if there's sure enough present. The other question is, let me make it a little bit more complicated. Let's say the patient didn't have a baseline genotype, or at least not one that you can access, and you run a DNA resistance assay. What does that do to your thinking? And there's an M184V in the DNA 5 years after initiation and success. Dr. Gephardt, you're the genotype expert in the group here.
Yeah.
You're asking me?
Yeah, I'm asking that. So this is like you talking to
So
me.
there's
This
a couple.
Taxi Driver.
I think there are a
Robert
couple
De Niro.
issues. One is, there is, so if they have an M184V, there is a potential that they could have some resistance, although I think it's low, but we have so many drugs, why would you run that potential? That's in my mind.
Yeah.
If it's an archived virus, though, it's possible that it's archived into some non-replicating part, which is the majority of viruses, but there's still a risk. So
Yeah.
it depends, there's so many drug regimens, why, in my mind, why would you do that? And it's possible you could just give them dolutegravir, frankly,
Right.
and with undetectable virus, and it could work. But
So you could do something more straightforward like dolutegravir rilpivirine, which is a single tablet regimen. You might think about whether hepatitis B, if it's present, you may want to cover it, you may not, but it's a little different than giving 3TC in the setting of hepatitis B, but assume that's negative. That might be a reasonable choice or a little bit less risky, even though the risk, we don't really know what it is, or probably if you treated 100 people this way, I'm guessing 2 might fail, have a failing regimen, but then if they fail and you worry about the dolutegravir resistance, you could have done something else. So I think your point's well taken. All right, so weight gain. I've always quipped that ever since integrase inhibitors hit the market, I've gained weight as I write prescriptions for integrase inhibitors. I think maybe that's happened to other people. But for patients, this is a fairly straightforward, common phenomenon. This is a 47-year-old woman who started BIC TAF FTC, had very low viral load, high CD4 count, did well. But now, 12 months later, her weight has gone from 145 to 171, which bothers her. And she's asking you, what do I do? So your options are yell at her, and then keep her on her current regimen, switch her to any one of these other variables here. I'll let you look it over. But some of them are TAF-based, some of them are TDF, some of them have doravirine, some boosted darunavir, some without any nucleosides at all, but continue, et cetera. Go ahead and vote, and let's see what our music does. Whoops. Nope, now vote.
The fast voters.
Oh. Dear Evan Hansen. This is the best song in the play, by the way. When they do the little dance at the end. Even in the movie, it's done pretty well, but on stage, it's fabulous. The most amazing trees. So you'll be amazed at my forest expertise. So again, well, fewer people, most people would try a switch. That's interesting. That's different than a year ago. What's new? Dr. Lennox, you have any thoughts on what you do here?
Obviously, this is very controversial, which is why you see a fairly good spread here. And, you know, part of the issue is that we have cohorts and trials where people are switched from the regimens like this and know that they're being switched and have an expectation that they may see improvement. And then if there is improvement, you know, we don't know if it's due to the fact that they started dieting and exercising. You know, to really answer the question, you'd need a randomized blinded study of people who'd gained weight and agreed to continue on a regimen that they believe is causing them to gain weight, which is also not very feasible to get a definitive trial. So I think that, to me, the data that looks most convincing is that there's something about TDF and efavirenz when used in combination that causes you to gain less weight than our other commonly used options. And that's probably some effect on appetite, in my opinion, based on the data I've seen of TDF efavirenz combinations. And I think that that's a special regimen compared to the others, from what I've seen.
So the punchline here is we don't know. There were some data, which is important when you come to a meeting like this, because you expect to get updated, and the update is, I don't know.
But I would,
That's kind of good to know.
But I would say, Mike, that there is an ACTG study, the Do It study.
Right.
And we're trying to answer this question, but it's been hard to enroll into that study because people, you know, the regimens are not that simple. But the Do It study is exactly designed to try to answer this question.
So we'd have to blind it, double blind it, to really get it what's what, I think. But there were some data at Croy, some new data that showed that maybe TAF is a little bit more associated with this, and maybe if you get them off of TAF, that could help, but it wasn't knock your socks off data. Joe, you didn't like it?
No. The solar study where everybody was on BF-TAF, and half of them switched to cabotegravir, no change in weight. They all went off TAF. You want this woman to lose 2 to 4 pounds? Switch her to TDF. I pretty much guarantee that's what'll happen. But that's what'll happen. She'll lose 2 kilograms. Those are the studies where you switch off TAF to TDF, you lose weight. You switch off TDF to TAF, you gain weight. The solar study, people didn't notice that, but everybody stopped TAF in that one arm, and there was no change in weight.
So, Dr. Walker, you're an internist, and you see people with diabetes every now and then, I expect. So what about in this setting using semaglutide, one of the glucagon agonists? What do you say here in this setting?
Yeah, so absolutely. I forget the stem of whether she had diabetes. Was that the case?
I didn't say.
Yeah, so in a patient that has diabetes, considering weight-negative drugs in combination could also be helpful if she's really well controlled in this regimen and wants to stay on it, and she might meet criteria for something like Ozempic, then that's something that might be able to counterbalance some of the negative effects of the weight gain in this drug.
Yeah, so right now, that medication is indicated for people with type 2 diabetes, and it works well, and it's associated with up to 20 to 25% weight loss.
Yeah.
It's
Pretty significant.
amazing. You talk about suppressing appetite, you put that with TDF, and they lose 75% of their weight. I made that up.
Disappear.
I made that up. Don't quote
It's
me.
actually now indicated for weight loss also.
It is,
It
yeah,
has
it
a
has an
separate
indication.
indication.
Right.
Meredith. Semaglutide, we're supposed to use. In this case,
sorry,
you can't. You have, in this case, you kind of have to use trade names because Wegovy
They're
is
different.
and Ozempic is not. So even though they're the same drug, which is a little confusing.
One advertises more than the other. But
Although obviously insurers can choose to cover it when you're using it for diabetes and not cover it when you're using it for obesity.
And I just want to add that I can get Ozempic covered for prediabetes also. Medicaid, so I am checking A1C or fasting glucose in everybody to try to get them a prediabetes diagnosis. And then we can start. And then, but Medicaid will not pay for it, at least in Louisiana, for weight loss because that's considered a cosmetic problem.
Well, I've heard people say, how many people have heard that? I've heard people say that if you go to the pharmacy to pick it up and you hum the song from the commercial, that you get your copay waived.
Can I?
I've heard people say that.
Can I add something?
Yeah.
And plug CROI. CROI is now open access, so
Yes.
that's really important. And there is a terrific Wednesday afternoon symposia that includes a beautiful discussion of weight gain by Patrick Donnell, maybe, or Donald O'Shea,
Donald
right?
O'Shea,
Donald
Donald
O'Shea, right? Who's Irish and has a beautiful accent, so it's fun to listen to. But he really, really hits the nail on the head. Sorry, with this the point about you can manipulate antivirals and lose 2 kilograms, but if someone is truly at risk and obese, we have to do other things. It's a really, really great talk.
Right.
So I would plug that.
Okay, so let's move on to a woman who's newly diagnosed, came in, was 6 weeks pregnant, and got a routine HIV test, and lo and behold, was discovered to have HIV. Labs are normal, B57's negative. I'm not sure if we're doing that anymore, but in this case it was. Wild-type virus, first pregnancy, okay to start therapy. Which is your regimen of choice in today's world right now? This is an answer that's changed pretty dramatically in the last 3 to 4 years. So let's go ahead and vote and see what our song is. Yeah. Follow my lead. You will see that. What's the most popular answer? All right, there we go.
Interesting.
Kristen Chenoweth says, TAF, FTC, dolutegravir. Now, 2 years ago.
Close race, though. This is still going on here.
Oh, okay. Well, when people are, that's called, I saw somebody else voted for that, so I'm going to vote for that.
Oh, is that what that's happening?
I think so.
Oh, there we go.
Oh, there it goes. See?
Ooh,
Yeah, it's like a horse race.
Yeah, I like
Yeah.
it.
It's like you're coming to the finish line.
Wrong answer.
Okay, so this is one that, TAF, FTC, BIC. Let's talk about what the panel will do here. All right, that sort of damned that one, didn't I? Okay. Dr. Del Rio, you want to take a shot at this?
Well, as you said, this has changed dramatically, and we all know about the dolutegravir data that came out, from Timpano's study, looking at the risk of neural tube defects. Later analysis suggested that wasn't indeed the case. I mean, it was really interesting to see that dramatic change. I think most people today would say dolutegravir, is a drug initially that you would start, and the question is whether you do it with TAF or TDF. But at the end of the day, the data from several studies suggest that you may have a little bit of greater risk of complications of pregnancy, such as premature birth or low birth weight, with TDF than with TAF. I would say the dolutegravir regimens are appropriate. I think bictegravir is probably also fine, but my recommendation on bictegravir would be if somebody's is on bictegravir then becomes pregnant, you don't need to change it, but I'm not sure it would necessarily be the one that you would start initially in pregnancy. I think it's really important to mention, and I'm glad it didn't appear at all, that cobicistat drugs are not recommended.
Yeah, so
I'm glad that dropped to the bottom. And efavirenz TDF FTC was something that we used for many years, and that was what typically was being used in pregnant women. But I'm glad to see that that's almost off the table now. And the data from primarily, again, the global data is really important because most pregnant women with HIV are being treated in Africa, and the data with TDL looks really good.
Yeah. Other comments, thoughts? You mentioned bictegravir. So right now, we're in a bit of a data-free zone, slowly collecting. So I think the consensus is you wouldn't necessarily initiate it
Right.
in this setting, but like I think you said,
But if
you're on, the patient's already on it and that you discover that they're pregnant and they've been on bictegravir, people generally are not switching.
Correct.
And continuing on, and so far that seems to be successful. So that's why, so I think starting it in this setting, not a whole lot of data to support. And the dolutegravir story is fascinating because it's just like efavirenz was in 2003 or 2002. When it came out, it was associated with neural tube defects. And then they did larger studies and said, oh, wait a minute, it's not any different. And that's a folate.
efavirenz, the data was primarily in non-human primates.
Well, yeah, but they also saw it in children born, if the mom was on it pre-6 weeks, right, when the neural tube forms. And it's all about folate at the end of the day. That's the take-home point. And so if you have someone who's planning a pregnancy, put them on folate right away. And that way you protect against, in general, neural tube defects. So that's a good take-home point. Jeff, you were leaning forward? No? Okay.
I would add there was a PK study with women at Croy with bictegravir, and there was a substantial decrease in bictegravir concentrations during pregnancy that then returned to predicted levels postpartum. That doesn't mean it won't work, but I would not use it as initial therapy in a pregnant woman.
Right.
I would be a little bit stronger than what Mike said.
Right.
I think it's fine if someone's suppressed and they're on bictegravir-based
Correct.
therapy, it's fine, but I would not use it.
And dolutegravir 3TC, kind of the same story,
Yeah,
right?
I would agree with that.
As you get towards third trimester. And so, generally speaking, TAF, which a year and a half ago we would say don't use, now there's studies that show that it actually did better in a way. So it's a TAF FTC dolutegravir is kind of emerging for de novo treatment, like this case. And that's one of the questions that I think you saw before on that pretest that 91% of people didn't have success.
Right.
So you can improve your success. 61% of you got that particular question correct. So now it'll be 100%.
Right.
Because we just talked about it, right? Dolutegravir, TAF, FTC.
And why did the TAF people, pregnant women, women who were pregnant, people who were pregnant, why did they do better? What was the correlate?
Tell
They
me.
did what? They gained
Wait.
weight.
Yes. Boom.
Because it's good for you
Yeah.
when you're pregnant.
So this is a summary I pulled from Raj Gandhi in that SEPAMO study. The neural tube defect data was reassuring. And this is another study.
This is the study where birth outcomes were improved
Right.
with
TAF.
TAF over TDF.
Right. Okay, so more data helpful, clarifying. Now, what do we do with the patient who has persistently detectable viremia? A lot of us have those folks, but I'm guessing up to 20% maybe of our patients. So this is a case of a 55-year-old guy who was diagnosed quite a while ago. The baseline HIV RNA was high, almost 1 million. CD4 count was low. The current, now 18 years later, HIV RNA is 85, but it's usually hovering definitely above 50, but usually less than 100 forever. CD4 count has not come up now nicely on a lot of different regimens, but currently is on dolutegravir, boosted darunavir, and 3TC. It doesn't have any resistance data available. So are you going to change this regimen to something simpler now? Yes or no, or not sure? Go ahead and vote. Dolutegravir, boosted darunavir, 3TC.
Okay.
So taking 3 different pills.
Yeah. Right. No. Affinavir.
Once a day or twice a day?
Once a day. Okay. So most people would stay the course. How about the panel?
You know, I would feel a lot more comfortable now changing them based on the data that's come out of Africa as part of the rollout of tenofovir, lamivudine, dolutegravir, that people with very significant nucleoside resistance did just fine, even though you would have been worried about both tenofovir and 3TC. You know, as long as you had the dolutegravir in the combination, they had really good rates of suppression. So I would feel comfortable switching them to a simpler regimen.
Yeah. But you're not switching them necessarily because the viral load's detectable?
No.
Okay.
As far as the
But he's
viral,
just on a complicated regimen.
It is complicated. It's
As
3
far as-
different
as far
pills.
as the
So that's a
viral-
reason to switch. But how many, would
as far as the
anybody
viral,
switch
as
because
far
the
as the
viral
viral
load's
load, I
85?
would ignore that. The problem is you have to ignore it and talk to the patient and try to explain
Right.
to them that neither you don't need to freak and the patient doesn't need to freak out for, viral loads. I would say this guy was 85. I mean, once they get above 200, you start worrying.
Yeah.
But as long as they're under 200, it's okay.
Yeah. Dr. Gephardt, you were going to say something.
I mean, the reason it's okay is they've done a fair number of studies that this is sort of a large viral reservoir, and I guess Dr. Saag's going to talk about it.
So stay there at the microphone while we go through this and get your comment. So this is a pathogenesis type slide, and you'll notice that in the lower right-hand side, all antiretroviral therapy does is prevent uninfected cells from becoming infected, full stop. That's all it does. But if you look at the upper right-hand portion, the latently infective reservoir that just sort of is hanging out there, the antiretroviral therapy does nothing to. It still persists. And there's a direct correlation to the original baseline viral load, in this case was about 1 million, to the residual reservoir. So larger reservoir. So these cells can spit out virus periodically that can become detectable in the plasma when you do your test, but there's no evidence at all of residual replication. So,
And furthermore, how many intensification studies have we done, Joe?
yeah, we've done. We ended up doing one, I think, in 1994. I think when Paul was a fellow, we added nevirapine to some other regimen just to intensify. It did nothing. So these are just basically data from. This is in essence from Bob Silicano's lab, but the take-home point here is that when you have cellular proliferation without de novo replication, which is the top part, these cells in the bottom will just spit out virus periodically, and you don't see any emergence of resistance because there's no ongoing replication. That's being stopped. Adding another drug doesn't help, and I think we just want to make that point. When the viral load goes above 100 consistently, I start to get a little concerned because usually it's below 100 in this setting. So you want to watch that person carefully, and if it starts going up above 200, that means there's probably some ongoing replication you want to do something about.
But then it isn't always there in the experience. You see it over 100, and I agree with you. You tell the patient to come to get a genotype, but you talk to them about here, and it's, they take their pills better, then they come back and they're undetectable.
It's undetectable. It's amazing how that helps.
The other
this
thing,
is-
you can't get a genotype unless it's above 500, which is a practical
As a
issue.
rule.
And then, can I just mention one boring thing? So there was a CROI presentation on immunology, which nobody cares about, but they looked at these persistently low viremic people versus people who were undetectable, and there was no difference in their immune response, which is really kind of interesting.
Yeah, it is interesting. So it probably is just the reservoir
Right.
spitting.
Yeah.
Yes. So this will go to Dr. Clement because she's going to talk about this later, and this is a preview of coming attractions for us today. So this is a 35-year-old guy. This is actually a case I saw probably 8 months ago. And he's had HIV for 10 years, doing well on Big TAF FTC, but he's coming back frequently, like frequently, very, very frequently. It's almost like I want to send him home with some IM Rocephin that he just injects himself with. But he has this, did I say it was frequent? Yes, it is. And so now, what are you going to do? Just keep treating each episode and tell him, hey, I'm being judgmental, your number of partners is a little bit too high and not helpful. Offer amoxicillin after each encounter, some doxycycline, send him home with some Cefixime, who knows? Let's go ahead and vote.
You didn't have an option of giving him a pack of condoms, did you? You didn't have an option of giving him a pack of condoms, did you?
That's right. Well, okay. All right.
Whoa, beautiful. beautiful.
Wow. So nobody went for the lower two. Dr. Clement, give us a preview of what you're about to show us later today.
Yeah, so this is still somewhat controversial, and the CDC has not yet really come down one way or the other. They, as I'll show in my talk, they give some guidance and acknowledge data on the efficacy of doxy-PEP, so post-exposure prophylaxis, 200 milligrams of doxy after a sexual encounter. But I do think this is a patient who really could benefit from doxy-PEP, avoiding frequent STIs and the possible complications from those, and the frequent visits to the clinic. So I think it's a good choice to really offer doxy-PEP here. I do think, as I'll talk about, there are pros and cons, and on a population level, I think we have to think seriously about what direction we're moving in.
So a lot of folks would say, wait a minute, if this guy's having 2 encounters, 3 encounters a week, he's going to be taking doxy intermittently, consistently. What about resistance to doxy? What do you know about that?
We have very little data right now as far as gonorrhea. I'll show in my slides the Staph aureus and Neisseria, the commensal Neisseria data. But in the doxy-PEP study, there were actually only, I believe, 56 cases where we were able to get resistance data, and so it was really hard to draw any conclusions from that. So I think time will tell. We need larger real-world data.
Right.
You know, I have now several years of not doing I was a PI for the GISP study, which is the gonococcal isolate surveillance project here in Atlanta. But consistently in our country, the resistance to tetracycline, doxycycline for gonococci right now is about 5 to 8%. Now, it's very different than what it is in France. In Europe, it's about 60%. But it may be that if we start using a lot of doxy, I mean, one thing we know about GC, it's really good at developing resistance really rapidly. So if we start using a lot of it, we may not see resistance, but I think we're going to start seeing an increase in resistance very rapidly. And that's why, and Meredith will talk about this, there's other strategies, and one of the strategies is using a meningococcal vaccine as a possibility. In fact, Colleen Kelly, will be starting a study here in town of doing a doxy plus a meningococcal vaccine.
So Dr. Del Rio just mentioned this, so it's the next question. Let's go ahead and vote. Would you give him the 4C meningococcal B vaccine just for grins and giggles? Go ahead and vote.
I would, as an option, refer to Dr. Kelly's study at the Hope Clinic.
The Magi or something?
So
Yeah, we're safe too.
Dr. Iran, who
We're-
said he
we're
liked
having a hard time recruiting, but
TikTok
anyway,
Boom.
Yeah.
Yeah, which was about Jonathan Larson.
Yeah,
That
the
last
same
song
ones.
came from Jonathan Larson from another play called Rent, which Dr. Gulick refers to as Rant. Oh, look at this, Dr. Del Rio. You could sell a bridge in Brooklyn, I think, if you wanted to there. Yeah, so it's reasonable. Data are emerging, right? Any further information on that? Meningococcal?
You'll be talking about the
you're
Yeah,
gonna talk
I'll
about
show
that.
a slide too. I'll advertise New Orleans as a Magi site too for the Bexera study. But I think a low risk intervention, right?
Right.
With
Yeah,
potential
UAB
benefit.
as well, so if we're adding on about the
Yep.
sites doing the study.
So he'd be a good
many
candidate.
of our sites are going to be part of this Magi study, so you'll be talking about the Magi.
So the return of the Magi. Stop Abacavir. So we got a guy
Which is because
who's
we have a lot of STDs in
returning
the
to
South.
you after 4 years in care. He had been treated elsewhere. He's on Abacavir 3TC, dolutegravir, doing well. Just doing well. The smoker, and he's 62. He has no negative cardiac history. He's already on atorvastatin just because, and a low-dose aspirin just because. Would you keep him on Abacavir or not? That's kind of the question here. Go ahead and vote.
Even though the most important thing is to get him to quit smoking.
I didn't process this question very well. But I think, yeah.
It says this play took place in Baltimore, right? Hairspray, you know this one? Yeah, all right. Joe Iran knows this one. All right. So most people would change. What does the panel think? Joe?
I think that anybody who can convince me of a patient who should stay on abacavir for any reason, I'll give you all the money in my wallet. at
Which is
lunchtime.
$1.50.
It's a little bit more than that, but usually it's about $5. But
Okay.
I think I have a 20 in there.
It's lunch
But
money.
if you can convince me that I can't trump you, or whatever, sorry about that.
Some people are saying that. Okay. Other thoughts?
I mean, I think the most important thing, you put it on top, right, is you got to get him to quit smoking. And yes, you can do I agree with Joe, why does he need to be on abacavir? But really, the most important intervention, switching antiretrovirals, if he doesn't quit smoking, is not going to really decrease his risk significantly.
So this is a little bit like the case we talked about where there was a 3TC mutation, and you go and you kind of say, aren't there other options? And the answer is yes. The data on abacavir is mixed in general, but the concern is that if somebody is currently on an abacavir regimen, that the cardiovascular risk is elevated a bit. But it's nothing compared to the risk from smoking in cardiovascular disease. So the reason I asked the question was to just kind of focus on the notion that, yeah, we can argue and dance on the head of a pin about abacavir, but the elephant on the pin is smoking. So
Yeah, but you can fix the abacavir like immediately.
Yeah.
And it's a twofold risk, and if his risk is 10%, twofold is a lot.
Right.
Right. So I agree smoking is bad for you, and you should get people to stop. If you can fix, there's no reason to give someone something that's even potentially toxic. I mean,
So
when you have
can I
other
ask
alternatives.
how solid is that data now that abacavir is cardio bad, for lack of a better word?
I think the majority of observational data support approximately a twofold risk. I would say by far. Though there are other studies that the VA has one on each side, actually, if you like the VA. They have one that says yes and one that says no, but I think the majority of the observational data would suggest there's risk.
Okay, so new skin lesions. 30-year-old guy presented back in September with new lesions on his buttocks, groin, back, face, febrile. Had several different sexual partners over the 4 weeks previously. He's off of antiretroviral therapy. His urine drug screen is positive for meth. So in addition to screening for STIs and mpox culture, which else would you do? Treat for molluscum. Start tocovirimat. Wait for cultures. If positive, then start the medicine. Would not treat. It's not indicated. No specific treatment. Just give the Jynneos vaccine. Phone a friend. Listen to some Broadway music.
This is Newsies, huh?
This is Newsies, yes. So now you're supposed to get up and dance and do flips and stuff and dance on newspapers.
Oh,
It was a movie first with Christian Bale and then turned into a musical. Okay, so most people would start, this is kind of an STI. Let's go back to Dr. Clement.
Yeah, I agree. I would start as soon as possible. The CDC now, given more and more data, urges you to be very vigilant in the setting of HIV infection with low CD4 count and elevated viral load. And we know just more and more data support that those folks have the worst outcomes. And so going ahead and starting soon is what I would do in this situation.
So in the United States, there were 57 deaths from mpox, and almost all of them were HIV positive, not on antiretroviral therapy with low CD4 counts. So would you start antiretroviral therapy simultaneously or soon, or what would be your thought there?
tough
Oh, that's
question.
a good question. We do, so Chloe Orkin in her presentation did describe cases of iris related to mpox. As far as I know, this is a data-free zone. I don't think it would be unreasonable to wait a week or two, depending on the presentation
Right.
that the patient has, I think.
I don't think we know. I would lean towards treating earlier. We can manage the iris.
I would think about this, the study that we did, the ACG study of starting antiretroviral therapy after an OI. I would think about this as an OI, and I would say, let's start him on therapy within 2 weeks of the onset of OI. So it doesn't need to be immediately. You can start him on TPOXX right now, and then within the next 14 days, start antiretroviral therapy.
Right. So this next one, I'll pitch down the line here to Dr. Lennox, because he spoke a bit about COVID when did a summary. So this is a 65-year-old patient of yours who has low-grade fever, cough, headache, and sore throat for 2 days. Rapid COVID test is positive. I'm going to come back to Dr. Walker because she's going to talk about long-term consequences. Rapid flu test is negative. Well-controlled HIV on dolutegravir, lamivudine, and also on rosuvastatin, carbamazepine, rivaroxaban, and vardenafil. And oxygen saturation is down a bit. So 2 days into treatment, would you use Paxlovid, brand name? Would you give a monoclonal antibody? This is in today's world. This is in the last week or two. Bebtelovimab. How about remdesivir as an outpatient? Molnupiravir. This new medicine that we heard about from Dr. Lennox, Antiretroviral, or no treatment? Go ahead and vote. Yeah, they're vaccinated once.
Once.
Oh, that's Hadestown. Yeah.
Interesting.
Okay. This is a good play, actually. Okay. So what about Pax here? Maybe I'll go to Meredith. I'll go to Tiffany first. Sorry.
Okay.
Tiffany, you want to go first? Yeah.
Yeah, so absolutely I would treat this gentleman. I think Paxlovid is a reasonable choice. He's not critically ill. He definitely has risk factors. From a long COVID standpoint, we don't have data yet long term. There's some exploratory endpoints that have been looked at in a couple studies to see if treating in the acute phase might prevent development of long COVID. There's some evidence to support that. We've seen, at least in observational studies, potentially remdesivir treatment has decreased the risk of developing long COVID. So both from an acute COVID standpoint.
What are you going to do about the drug-drug interactions with rosuvastatin, carbamazepine, and rivaroxaban?
That's a good point that I had not considered.
No, I mean, I agree completely that it's optimal to use Paxlovid, but it may not be possible. So moving back to the choices, anything else you see here that you might go with?
I mean, you could potentially do the remdesivir as an outpatient. I think it would have less hepatotoxicity than the Paxlovid. And I think that the key being just trying to get the person treated as early as possible to prevent long-term risk.
Yeah, it's a tough call. So, Jeff, tell us if let's say this Antiretroviral is now available. It's a PI, right? But it's not boosted.
Right.
But it's probably going to interact with some of these same things, so you're not a whole lot better off. What would you do here?
I was very concerned about the drug interactions, so I agree that, the data would support using the outpatient remdesivir if you can actually arrange to give it. The monoclonal antibody combination is probably not going to work, given the circulating COVID, and the Antiretroviral, if we had it, would probably work. Molnupiravir is an option. It's not as good as Paxlovid in people who can get both. But if you can't get it, it does have antiviral activity, although it wasn't as impressive as the remdesivir and the naltrexone.
This is a hard case, and I think we made most of the points. What we've been doing is trying to get them remdesivir outpatient, and we have it set up, but it takes effort. And it also means recurrent trips for at least 3 days back to an infusion center. The infusion's relatively straightforward. It's not a major deal, but the drug is an antiviral. It works really well, and the drug interactions are few, relatively speaking. Molnupiravir, okay, just not great. Carlos, you have a thought?
Yeah, I mean, I agree with you. I think the challenges with the infusions is, at least the challenges we have here, is many infusion centers don't want to bring somebody who's COVID positive. The infusion centers tend to be a cancer center, so it's a big issue. And if it's going to take you 7 days to get it organized, you miss your window of opportunity. So I think Molnupiravir is not a bad option in somebody like him. And quite frankly, I think that the data from the panoramic studies and other studies, granted, it may not be good as Paxlovid, but it's much better than nothing.
Yeah.
So I think this is a patient that I would really feel very comfortable starting Molnupiravir. He's 65, is not a reproductive age person.
Yep.
I mean, I think this is the right patient to start Molnupiravir.
Yeah, I mean, to me, it's scary that his O2 stat is 94. That's not normal. I mean, maybe he's a smoker and has lung disease. I didn't, but that's not normal. So that would really make me nervous. I mean, I've certainly managed people on apixaban. It depends a little bit on the indication for anticoagulation. The rosuvastatin I wouldn't worry about.
You just hold it.
So I wouldn't give up immediately. I don't know. I've never looked up rivaroxaban, so I don't know. Maybe it has a bit worse
The
interaction.
carbamazepine is really the killer here. That's the
Joe,
one that you can't dance around very
Joe, one thing we don't know about this patient, or maybe I missed it, I was also concerned about the O2 sat, but we don't know if he's Caucasian or African American. And one thing that's surprising about the pandemic is how poorly quality checked these transcutaneous oxygen sensors are across a variety of skin tones in the United States. It's
Well, just real-
really sobering.
One quick personal anecdote. I think a lot of you know that I had COVID back in March 13th. It was a Friday the 13th, 2020, before we knew a whole lot. And I had a pulse ox at home, and invariably at night at 2 a.m., my pulse ox would drop, and I'd just start trying different fingers until I found one that gave me a better number. And that tended to work. It was very therapeutic. So you can try that at home if you ever get COVID. The take-home point here is that none of the monoclonals work because we've evolved into an Omicron abyss, and they weren't designed. Now, why the companies aren't developing Omicron-specific monoclonals, which isn't a terribly tough technology question, I think it's a marketing issue, and I wish somebody would do that. They certainly would be used. Final question here. A guy transfers to the clinic who's got HIV and frequent meth use and not been on therapy for over 3 years. You don't have any data. You know that just on his report, he's been on Antiretroviral and Bacavir and Lopinavir and AZT in the past, and was recently on dolutegravir rilpivirine the last time, and had success. And now was hospitalized. TAF-FTC was added, so on this crazy regimen, you get data from a darunavir, Kobe, 3TC, dolutegravir, and the viral load came down a little bit but didn't go to less than 100. So you're sitting here treading water, wondering what's going to happen with this regimen, and this is some kind of crazy phenotype that doesn't look too good. And it also looks bad for all the integrase inhibitors, and has multiple mutations. And that's just to remind you that those are bad, evil.
Mike, what is the person on now, though? I got mixed up.
He's on dolutegravir, darunavir, TAF-FTC, and
And the
I think,
dolutegravir is twice a day.
yeah, darunavir boosted, 3TC and twice daily dolutegravir.
But it's not working.
So this will come to you, Joe, because you talked about some of this. So one of the, I'll just let you look at them for a second. There's a maturation inhibitor, the FOS, and different things. And so let's go ahead and vote.
Where's the Luzumab when I need it?
Yeah. Doravirine is on there at the bottom. Oh, and so is eculizumab
Oh, yeah,
at the
I see
bottom.
it,
I don't, I'm sorry, I don't know.
I couldn't.
the point is just in highly resistant, you've got a few different options now.
Can't hear that one very well. All right, a lot of people went with your sort of drug du jour in your talk, lenacapavir. What do you think?
Yeah, the only thing I would say is this is super difficult, right? And I didn't see the protease mutations.
It was a 10 and a whole bunch of
Yeah,
other
okay, I didn't, because I don't know what the Drumovir-Cobi is doing in this setting, but I would probably also give the person fostemsavir and lenacapavir, because the dolutegravir may have some activity in that setting, but not much at all. If there are multiple Drumovir mutations I didn't see, it's going to have kind of very modest activity. So I would be really worried about this person completely running out of options. He's already on twice daily dolutegravir, which I wouldn't stop. Yeah. So I would give lenacapavir 100%, but I would probably also give fostemsavir.
What about ibalizumab?
I don't know that there's any advantage to ibalizumab over fostemsavir, and fostemsavir's oral. It is twice daily, but it's well tolerated. So I don't see where I would pull that out. And I think this is exactly the situation where lenacapavir is useful. And if you look at the data from CROI at the subsetting data that lenacapavir, when given with fostemsavir, actually had, I think, the highest suppression rate in this setting. So I would give both. And I would wonder whether the Drumovir-Cobi cysteine is doing anything. But I would need to look at the mutations really carefully.
I think the take-home point here is that there's good news and bad news. The good news is that this is rare.
Yeah,
I mean,
right.
the number of cases
Very
we see like this, you can count on maybe one hand over the last 3 to 4 years in our clinics, and that's remarkable. The bad news is that if this regimen fails, whatever you switch to, he's kind of toast, and just not good. And the sad thing is that probably a way that he ended up getting in the position where he's got multi-drug resistant virus is inadherence, and you got twice daily drugs that we're giving him, and that's the hardest to comply with. So it's a mess. These are data from the CNICs that a lot of people, Joe and others on the panel, have participated in, and the actual number of people that have limited treatment options, meaning less than 2 drugs, that are active is vanishingly small in the current era. And what's even more remarkable in that analysis, even those who had limited treatment options, which is the red line, you can see that as the integrase inhibitors came on the scene, they did as well virologically as those without limited treatment options, which I thought was amazing. So in conclusion, we're going to wrap up. Antiretroviral therapy should be initiated in general with the integrase strand transfer inhibitor as close to the time of diagnosis as possible. Weight gains associated with this, and the weight gain may be reversed a little bit with TDF. Dolutegravir and TAF are drugs of choice in pregnancy these days, and I'd advocate giving folate as much as you can. Simplification of regimens is doable. Some points we made out. We talked about episodic doxycycline. We're going to hear more about that from Meredith in a little bit. And watch for drug-drug interactions when you're using SARS-CoV-2 things, and the variants are making monoclonal antibodies ineffective. So a lot that we covered. Appreciate your hanging in there with us. There was a comment that while we're doing these cases, especially but during the talks, if you can keep comments between yourselves a little bit to a minimum, because it's interfering with some folks' ability to hear. And I think we'll wrap up here. We got lunch for about an hour. We'll come back right at the top of the hour at 1 o'clock. Thanks to the panel for a great job. Thanks for all you guys for hanging in there with us.